much, Gayatri, for that sweet introduction. Preeclampsia is a significant public health threat in both the developing and the developed countries, and more so in the developing countries, considering that we have more important causes of maternal mortality like obstetric hemorrhage, sepsis, thromboembolism, but still medical interventions in preeclampsia do not allow a positive outcome in most of the cases in preeclampsia. So now I start my lecture with how serious can it be and what is our current understanding. And before that, I bring to you greetings from my beautiful city of lakes. This is after we have an abundant rain this season, and you can see the beauty of Fateh Sagar, which is spilling over. Now, this significant article from Hossangbutt in 2011 looks at the WHO audits which were carried in 2004, 2005, and they have specifically underlined the significance of preeclampsia in the developing countries. You'll find that it is about 7 times higher in the developing countries. And when you look at the incidence of eclampsia, you find there is a wide variability. One case between 100 to 1700 pregnancies. And in the developed nations, it comes down significantly to just 5 to 7 per 10,000 deliveries. So what is our current understanding? I need to go into a bit of pathogenesis and pathophysiology before we embark into some of the significant mortalities or morbidities that occur with it. Now, the immune factors which are responsible, especially AT1, AA, oxidative stress, and NK cells, and other factors that lead to placental dysfunction. Placental dysfunction causes release of anti-angiogenic factors, especially SFLT1 and soluble endoglin, and this is responsible for these end-organ damages, hypertension, and proteinuria. Now, there is a fight between the anti-angiogenic factors and the pro-angiogenic factors, and here you see that in normal pregnancy, to maintain the vascular endothelium, the vascular health of these vessels, you need a stable level of vascular endothelial growth factors and PIGF and TGF beta 1. And you'll find that this results in endothelial health relaxation. While in preeclampsia, you find that there is an increased secretion of the anti-angiogenic factors, SFLT1 and soluble endoglin, and they tend to inhibit the growth factors, especially vascular endothelial growth factors and TGF beta 1. And you find that this causes a decrease in the prostacyclin levels, nitric oxide levels, and an increase in the procoagulant proteins. Always remember, endothelium is very important to maintain the permeability, the vascular tone, and the coagulation cascade. So most of the problems that you envisage is because of these, the basic defect of endothelial dysfunction. Now, something about the abnormal placentation in preeclampsia. Some of the workshop students have looked into it. In normal pregnancy, you find that the fetal syncytial trophoblasts, they invade the maternal spiral arteries, convert it into from resistance vessels to large capacitance vessels, and this sustains uteroplacental perfusion as well as fetal growth. Now, when this invasion occurs, there is a changeover from epithelial to endothelial phenotype. Now, in preeclampsia, what happens is there is just superficial invasion of the maternal spiral arteries. There is no conversion from an epithelial to an endothelial phenotype, and you find that these resistance vessels are just narrow vessels which do not sustain your uteroplacental perfusion. Now, if we had certain predictors which would forewarn us that this patient is going to go in for preeclampsia, life would be much easier for the parturian, the obstetrician, and the anesthesiologist. So there have been some research which is going on, and you find that maternal levels of SFLT1 and soluble endoglin. And soluble endoglin found in the first trimester of pregnancy have a high sensitivity and specificity in preeclampsia as compared to the other hypertensive diseases of pregnancy. Another important research was about a novel biomarker found in the first trimester in maternal blood, that is plasma protein 13 RNA. And a recent research also talks about a preeclampsia-like syndrome when autoantibodies were injected into the mice, which were against activated the angiotensin type 2 1A. But still, this is in a very preliminary stage of research. Now, the gravity of the situation in this editorial in the International Journal of Anesthesia in 2011 looks at the CMAS of 2006-2008. And in this triennium, they found significantly that 22 cases who died in preeclamptic women were suffering from intracerebral hemorrhage. And what was alarming was that 91% of them had substandard care, and this related in terms to inadequate antihypertensive therapy. So there is a need for effective control of hypertension, especially before general anesthesia for cesarean sections. And all preeclamptics who have a blood pressure about 180 millimeter mercury should be labeled as medical emergencies. Now, they have highlighted the inadequacy of measuring your blood pressure with non-invasive automated blood pressure monitoring. And they say that the key hemodynamic variable should be monitored by an invasive intraarterial line. There have been some other changes in this. We'll go to this later on. And the paradoxical effects of oxytocin. It is very, very significant that these patients do not respond uniformly to the doses of oxytocin that you give. And synthetic oxytocin, as we have all learned, that especially this article from Dyer et al. In 2008 looked at the effect of oxytocin in low doses at 2.5 international units, and they found there was no increase in the cardiac output. But when Langester looked at it, he used 5 international units of oxytocin in 18 patients, and what he saw significantly was there was a decrease in the systemic vascular resistance, in the systemic arterial pressure, an increase in heart rate, and in 5 cases there was a decrease in cardiac output, which was perplexing. So since there is a more unpredictable response, the conclusion was that you need to use lower doses of oxytocin to maintain hemodynamic stability, and also blood pressure monitoring is not a good enough indicator. So then, recent articles have looked at cardiac output as a key hemodynamic variable for monitoring the hemodynamic status of these patients. And these 2 articles, especially Dyer, found that in his patients there was a wide range of cardiac output, ranging from 4 liters per minute to about 10 liters per minute, with a wide variation in the systemic vascular resistance. And they found that continuous invasive arterial monitoring would especially be beneficial in all those patients who were severely preeclamptic, who were coagulopathic, who were morbidly obese, and who required nitroglycerine or sodium nitroprusside to manage their hypertensive crisis. So this cardiac output monitoring is coming up as a key hemodynamic variable to look out for in future. Now the fluid controversy, another controversy, whether it should be crystalloids or colloids. Remember, whatever you infuse is going to come out into the extravascular space because it is associated with a capillary leak syndrome. And remember that the colloid osmotic pressure is already decreased in preeclampsia and further goes down when you infuse your crystalloids. And if you infuse your colloids, it gives you temporary relief, and you find that if the patient goes into pulmonary edema, you have had it, it's really difficult to get this patient out from pulmonary edema because they are not amenable to diuretic therapy. Now, benchmarking is a very important technique to avert avoidable complications that can occur in obstetrics. So what this group did was they looked at 5 tertiary care centers and 4 of them were at New South Wales, Australia, and 1 was in Vancouver, Canada. And what they looked at was the fluid infusion strategies in these different units and what was the outcome or what was the incidence of acute pulmonary edema. You can see the wide variation. In Unit F, it was 46 per 1,000. So what they did was made them restrict their fluids, looked at the acute pulmonary edema incidence after 1 year, and they found that there was a dramatic reduction to about 2 from 46. So benchmarking, again, is a very important technique to bring down avert complications. Now, regional anesthesia, hematoma is another significant problem we all face, and we wonder whether we need to give our regionals when the platelet counts are low. So what the current consensus says is that if the platelet counts are less than 75,000, if there is a normal APTT, PT, and fibrinogen levels, and more importantly, if there is not a significant fall from the first values, then you can go safely into the epidural space. Another significant complication is your HELLP syndrome and acute fatty liver of pregnancy. Sibai et al. Came out in Lancet 2005 about the diagnostic criteria, how you could diagnose HELLP syndrome. There is not much of a difference between the lab values of AFLP and your HELLP syndrome. And they said that any evidence, clinical evidence of hemolysis, a platelet count of less than 1 lakh per cubic millimeter, AST of more than 70 units, and the serum LDH of more than 600 units should warn you about impending complications like DIC, placental abruption, acute renal or liver failure. AFLP is a more serious complication, though rare, but the mortality rate is about 18% with a perinatal mortality of about 23%. Again, mortality occurs because of liver failure, bleeding disorders, and encephalopathy. Now, post-preeclampsia outcomes, a very significant article in What is New from Ruth Lindau. And what she looked at was, she declared that preeclamptic women have risk markers for late life diseases, whether it potentiates already existing diseases or it's a risk marker. They have more chances of hypertension, more chances of ischemic heart disease, strokes, and VTE. And what they said was that this article in the New England Journal of Medicine talked about PRES, that is posterior reversible encephalopathy syndrome. They also said that eclampsia which occurs with encephalopathy is because of the underlying PRES condition, and they found that it is very important. The role of the anesthesiologist is very important. Intraoperatively, you should be careful about not raising the blood pressure, getting it out of the cerebral autoregulation limits, because you may cause white matter damage and cause prolonged cognitive dysfunction in these patients. So how serious can it be? We conducted some audits in our department and published it in 2011 and 2010. And we found that the preeclamptic patients would land up in our ICUs mostly because of the following conditions: severe hypertension with neurological injuries, severe oliguria requiring dialysis, acute liver failure, could be an abdominal catastrophe, liver rupture, or hematoma, repeated convulsions, DIC, HELLP, or severe PPH, cerebral hemorrhage and edema, pulmonary edema, and CHF. Some of these problems are going to be discussed by Dr. Ramkumar and Dr. Neerja in subsequent lectures. And so the take-home message would be, you need to be very conservative in your approach about fluids and oxytocin. Cardiac output measurements in subsequent years would become the key hemodynamic variable where severe preeclampsia is concerned. Keep the blood pressure close to a baseline to sustain the uteroplacental infusion. In fact, Nigan-Key says in his, one of the recent articles that they should be kept at 100% of the baseline to maintain the uteroplacental perfusion. Use platelet counts trends rather than a single value along with your clinical judgment. for giving regional anesthesia, and anesthesiologist should always be a major part of the multidisciplinary team for pre-eclamptic care. Thank you.